Hello and welcome to the first webinar on calcified lesions. My name is Adam De Belders. I'm an interventional cardiologist from Brighton and Sussex University Hospital in the United Kingdom. And helping me with this webinar, it's a great privilege to have Dr. Bruno Farah, cardiologist from the Clinique Pasteur in Toulouse, and Sagar Doshi from the University Hospital in Birmingham. By the end of the webinar, I hope we'll be able to talk about the new rotational atherectomy equipment, which is as yet not available, but it is a marked transformation on the ease of use of this equipment, and we'll be able to see it in action and all the new modifications. The second part of the webinar, we're going to have a look at the standardized protocol for rotational atherectomy as emphasized in the European consensus document. And we're going to use a specific case where we can look at all aspects of the rotational atherectomy technique and go into forensic detail to discuss what is the best way to use it in contemporary practice. And in the final section, we're going to look at some of the less common complications which happen with the new modified techniques that we use. And if you're unlucky enough to have some of these complications, we've got our experts here who'll be able to help us not only avoid them, but get out of them as we do. So on the screen, we can see a characteristic lesion that for those of us who practice rotational atherectomy is a very common indication for the art of plaque modification with this technique. But if I could ask you, Sagar, are there other indications for this that we can use as well?
Well, certainly in addition to the undilatable lesion, which is effectively sort of a class 1 indication, I think it's entirely reasonable to also use rotational atherectomy in just a heavily calcified vessel, which you haven't actually approached yet with a balloon, with the purpose of improving balloon and stent delivery and facilitating stent expansion to reduce the risk of restenosis and stent thrombosis.
Bruno, do you have any other comments to make about the use of this tool?
Well, I fully agree with Sagar. I think that the first step is effectively when you face this type of lesion, undilatable lesion. The second step will be maybe if you have difficulty to cross with a balloon, and for me, for example, if I cannot cross with a 1.5 millimeter balloon, I will switch immediately to do a rotablation. And finally, the third step is before any action on the lesion, before any attempt of crossing, if you face an heavily calcified, diffuse lesion, and you anticipate difficulty and even higher risk of complication, then you will move to rotablation.
So perhaps, Sagar, we could go back a little bit when this technology started off. What is it? Tell us about the history of about where we were and where we are now.
Well, we've come a very long way since the early days of rotational atherectomy, which has been a technique that's been available for at least 2 decades. And certainly in the very early days of rotational atherectomy, the emphasis was on heavy debulking with large burrs, often greater than 0.7 burr to artery ratio. But we've learned, and through randomized studies, really that sort of technique isn't required. And randomized studies have shown that burr to artery ratios of less than 0.7 achieve the same lesion success, but dramatically reduce the complications. And that's very important. So that is where we've come really, I think, with rotational atherectomy, and this modern concept really is of plaque modification, doing enough to the lesion to facilitate balloon expansion and stent expansion.
And this is one of the sort of take-home messages from the whole webinar, really, is about the change in purpose of this technique to modify plaques to allow stent deployment rather than this idea that there was histological gain by removing the tissue in some debulking manner. And on the background of those techniques, of course, it led to some complications which have become of historical notoriety with this technique, which I hope with the new techniques are now settling down. But we'll talk more about that later. Bruno, perhaps we could move on to the new equipment, which is still yet to be available, but we're fortunate enough to have access to it here today. Perhaps you could go through the stepwise changes that the technology now has.
So Adam, as you may know, there is 3 main components. The first one is the burr, and there is no change on the burr. Then you have the advancer, and there you will see that there is some important modification on the advancer. And finally, you have the console, which is completely new. First, we will look at the console. You can see on the console a screen easy to be seen. You have also this ergonomic button over there that is there to modify the speed, and you will rotate it very simply. And finally, you have 3 plugins to easily plug the different connection. The first one is the fiber optic connection, and I could plug here. The second one is the power connection, and you can see here there is a small arrow, and you will plug easily the arrow in front of the other arrow like this. And the third one and the last one is the gas that we will easily connect also here. So as you can see, 3 different connections, very easily to connect and to individualize. So really very user-friendly now.
And on the console itself, it looks like a very simplified messaging system.
Yeah, you can see here it's written the DynaGlide, and you can, with the button, see clearly what is the speed that you are activating. Third component, yes, it's here, it's the advancer. And you can see that on this advancer there is 3 main modifications with 3 new buttons.
So no foot pedal?
No, that's the new one. There is no more foot pedal, so you don't need to coordinate perfectly the feet with your hand. The first button is there, is on the top of the knob, is just to activate the burr. So you push on it, and you will then after do your pecking motion with your burr.
So simple on and off,
oh,
and
yes.
then you press it again to turn it off.
Yes, that's correct.
Yeah.
You just repress and it stops. So you don't need to push anymore on the pedal. You just press on the button, do your pecking motion, your short run, then you repress on the button and it stops. Second modification, second button. This is the DynaGlide button to switch from the normal way to the DynaGlide mode. It's just over there. So you press. Here you will see on the screen that the DynaGlide disappears, but because I was on the DynaGlide mode. But now I repress on it like this, and you can see immediately that DynaGlide has been activated. So easy also to be activated. You don't need to have this small pedal that you had on the right side of your feet. And finally, the last button is this one, is the button that you will use to perform the DynaGlide. So when you are performing the DynaGlide, simultaneously with your left hand, you will push on the brake, push on the DynaGlide system, and then you will pull back your system and your wire, pushing your wire.
So very simple mechanism.
Very simple mechanism.
What happened if you sort of were on DynaGlide and you press the main button?
That's a good question, because there is a safety mechanism. So even if you are on the DynaGlide and you push on this button, nothing will happen. This is a safety mechanism.
So sometimes the despondent staff who have to get the whole kit out for rotablation, in fact, this can just be relatively straightforwardly kept on a simple console. The foot pedal's gone. We still have the gas turbine or the wall for whatever it is that delivers your gas. There was some concept about other forms of power, but I think for the time being it's going to remain with the traditional means. So in conclusion, on the slides now you'll see the simple console mechanism that Bruno elegantly described, with a very simplified appearance and a speed button. The new advancer system, which has 2 very simple switch-on, switch-off mechanisms with inbuilt safety to allow traditional rotational atherectomy. And I hope very much these new modifications will allow people to get up their learning curve for this procedure very much quicker than has hitherto been the case with the perhaps more cumbersome foot pedal techniques. There's also a rather neat little cart system which will hold everything together, which you can push in and out of your lab. If you see the video work in a moment on the screen, you'll see it just advance and go forward, and it has a few safety mechanisms. For example, if the speed of the rotational atherectomy drops below a certain amount, There's a colour-coded system, perhaps yellow there, shows that it's gone down below greater than 10,000 revs per minute, which is something we're trying to avoid complications. And then at the end of the procedure, if you press on the Dynaglide, a green button appears, which gives an indication to you that the Dynaglide system. So I think we must congratulate the engineers who've come up with a very much more simplified device, and I hope we're all looking forward to it having more general use and will allow us to do this very elegant procedure for some of the more complicated lesions that we deal with. So we're going to go back to our case now that we had right at the beginning. Now we've seen the new equipment, and we're going to talk in some detail now about the various aspects of the technique that was discussed in an expert consensus document, where different aspects of the procedure were discussed. And I'm going to get my colleagues here to look at this in more detail. The main purpose of rotational atherectomy is plaque modification. The concept of debulking has now gone, and the only purpose of this device is to facilitate delivery and stent deployment. There are some issues about the rotor wire, and Sagar, perhaps I could ask you to expand on that for us a little bit.
So Adam, there are two rotor wires available, and they are unique to the procedure. They are the rotor floppy and the rotor extra support. The principal features of these two wires are that they are stainless steel in construction, solid stainless steel. The rotor floppy has a shaft of 009 tapering down to 005. The extra support goes from 009 down to 005 and doesn't have this 007 transition point, and they both end in a spring coil platinum tip. Now, in contrast to standard workhorse 014 wires, these wires are very different. They are prone to kinking, they have no memory, so that once you bend them, they will retain that bend. They're quite prone to fracture as well. And their torque characteristics are completely different, and so we can talk about which wire to send down first. So they are quite unlike any other wire that you normally use in standard practice.
And understanding the fragility of the wire, we've developed some techniques to reduce the chances of their running into problems. Bruno, perhaps you could share some ideas about that.
Well, you are perfectly right, Adam. When you have some difficulty, you know, when you face, you know, some tortuous anatomy, some difficult, angulation to handle, then you can use your standard wire, exchange on the microcatheter for the rota wire. I think that more and more when you want to use the rota wire and you have to face some difficult anatomy, do not hesitate. Use your standard wire, use a microcatheter, and then exchange it for the rota wire.
I would absolutely agree with that. I think for very simple lesions, it's entirely reasonable to perhaps approach it with the rotor wire, but because of its poor torque characteristics, it's just really not a great wire for complex lesions. So I would absolutely agree with Bruno's comment that for anything other than a standard simple lesion, cross with your favourite 014 wire and then use any other sort of microcatheter that you might wish to exchange out to a rotor floppy wire, and that will protect the wire also.
There is an extra support wire. Do you have any comments about the use of that?
There are schools of thought on the rotor extra support. In my view, and I think I share that with others, that the rotor extra support really has a very, very precise role, really. Ideally, you don't want to use it in all lesions because it's going to lead to wire bias, and therefore potentially increasing the risk of perforation in a tortuous vessel particularly. And there is a school of thought that thinks that really the rotor extra support should only be used for aorto-osteal lesions where you potentially require a little bit more support just to ablate the ostium. So really I think there are very, very few situations in which you would use an extra support wire, and really the vast majority of lesions are probably more safely managed with the floppy wire.
Do you have concerns about the extra support wire at all,
Well,
Bruno?
I fully agree what Sagar said. I use the floppy wire in most of the case, and the only indication for the extra support is when you face an ostial right coronary lesion, because you will need some support at the moment of the rotablation, because you need to disengage the guiding. So it's maybe the only indication when I think to the extra support rota wire.
And let's go back a little bit and let's just talk about access to the heart. Very much a European radial against non-European femoral. Is there any data or perhaps your own experiences which would help you make a decision, Sagar?
Certainly, which access you use is important. Obviously, there is a much lower complication rate with bleeding risks going from the radial artery. And I think with the modern technique of smaller burr sizes and knowledge that you can achieve in most cases with up to a 1.75 burr, it really means that the radial route can be used for nearly all cases. And there are sheathless guides also which enable you to use on those rare occasions when you need to use a 2.0 burr, also to go via the radial access. So I think there are a few situations actually where you now need to consider femoral access, and I think that's one of the benefits of the modern technique really for rotational atherectomy.
I think to those people who do use femoral access, and there are plenty of them, I think because it is a 6 French procedure now, and there's been a substantial reduction in the use of 2B3A inhibitors, whereas I accept there are still an increased risk of bleeding. I think they have reduced substantially in that group. But I think Oldroyd's group did look at the comparison between radial and femoral, and essentially there was no difference, I think, in the outcome or the ability to perform the procedure.
Correct.
But there was, I think, just a little bit of noise of bleeding still down in the femoral artery procedures. But perhaps moving on from that, perhaps it's more important about your guiding catheter for the procedure. Bruno, perhaps you could have some thoughts on that.
Well, as you may know, you need a strong support to perform rotablation. So you need a guiding that allow you to have a good support at the first thing. In terms of size, normally the size of the guiding is dictated by the size of the burr. But as now we are using more and more small burr, 125, 1.5 in the most of the case. So most of the case can be done with 6 French guiding catheter.
And perhaps pushing you a bit, what cases might you use a larger catheter?
Well, when you have very large arteries, sometimes you may use a 175 millimeter burr, but even with some 6 French guiding catheter with large lumen, this is able to perform a 175 millimeter rotablation. So it's very rare that I upgrade I use a 7 French guiding catheter, except very large artery when you maybe need a very complex balloon technique.
So it's one of those myths we need to explode in the webinar about this idea that the burr to artery ratio is a key element of what we need to measure. And in fact, when you use burr, it's essentially use a small burr, modify the plaque, and perhaps we can talk. Do you always use a 125 or 1.5? How does your decision making go? And when do you test with a balloon?
So first of all, we use a small burr, 125 to 1.5 millimeter. In most of the cases, most cases 125, 1.5. It's very rare that I start with a 175. So often I start with a 1.5 millimeter burr or 125. It depends of the size of the artery. 3 millimeter, it would be close. It will be a 1.5. Less than 3.0 millimeter, it will be 125. I will downside the size of the burr if it's quite tortuous artery. So in tortuous anatomy, even if it's a 3.0 millimeter artery, I will use a 125 millimeter burr.
Do you have any thoughts on that?
Yeah, I would agree with everything Bruno said, but I've got a couple of other small rules that I add in. If there is, for example, a napkin ring of calcification and I've been unable to cross with my microcatheter, then I will always, in that situation, use a 125, which I'm sure Bruno would agree. And for very long lesions also, very tight lesions, I think making a channel with a 1.25 millimeter burr means that you potentially reduce the risk of of slow flow, not due to microembolization, but just due to sludging up of the vessel by the channel. So those are the slight modifications. But yes, I would agree that I do start most cases with a 125 or a 1.5, and only rarely with larger burrs. It's just really not routinely necessary.
I mean, the key message, of course, here being that if you have a smaller burr, then you will cause less distal embolization. You've got less risk of complication. And because you're modifying plaque and not debulking, then the function of what you're trying to achieve can be done much safer than the old techniques, which we've got to put aside.
Absolutely.
Absolutely.
Perhaps I could ask you to use the advancer, Sagar, to just see what your technique is like, and what the dottering or pushing or perhaps the pecking technique.
So the optimal technique is one of a gentle pecking motion where you are applying mild pressure. You have to apply a little bit of pressure, but obviously you've got to be quite gentle with that. You're also watching, and your technicians are telling you about the burst speed. So it's a gentle forward pecking motion and keeping your runs to around 15 to 20 seconds. What is not recommended is a fast dottering motion, which we have seen some operators use, and also sustained long forward pressure also will just generate heat, will generate larger particulate debris, potentially increases the risk of slow flow and peri-procedure infarction, and really will run you into trouble, because if you push too hard, you also increase the risk of the burr jamming. So it's a gentle forward pecking motion, keeping an eye on the revs and keeping an eye on time.
Good. I'm just going to intrude on a couple of questions we've had already from the webinar. There's a question here about the use of the Guidezilla catheter to extend your rotational atherectomy device into the distal coronary tree. Have you got some experience of that at all? It's certainly something I've done occasionally for very distal lesions, where essentially one of the restrictions is, of course, you can only advance within the period of advancer, but you do have to use a large guide to get the sufficient size in. But certainly you can use supported Guidezilla catheters for that.
I will add maybe just a technical point. If you use the Godzilla or the guide liner, you may be able to advance the burr, but do not retrieve the burr with the dignite, because I think that it's not compatible with the Godzilla or the guide liner.
And Bruno, if I can just come in on there. So if I understand the question, what they're suggesting is that you basically are increasing the length of lesion that you can treat. But actually, there is another technique for doing that too. Now, it's an advanced technique, but basically it is that you lock the burr in a back location and then activate the burr, disengaging the internal brake and pushing the whole system forward, so that you now adopt a new run length. And that's actually the technique that I use, and it obviates the need for using other guide support catheters. So that's the technique that I personally use.
Yes, and with the smaller burrs, it's much less likely to cause any trauma with that. And we've had another question about activating Dynaglide as a technique for getting the burr up to the vessel. I don't know if you have any thoughts on that. It's commonly used, but I don't know if there's any issues or you'd warn against any techniques like that.
I mean, personally, it's not a technique that I use, and I mean, obviously, what you might be doing that for is to just advance the burr quickly up the guide catheter. The concern with that historically is that obviously the diamond crust is on the front of the burr, and any forward movement in the guide is going to potentially ablate the guide. And certainly there are the case examples of you ablating the end of a guide catheter with aortoosteal lesions. So bringing the burr back with Dynaglide is perfectly reasonable, because the back end of the burr is obviously doesn't have diamond crust and won't ablate the guide. And those are my views, and it's not really necessary, is my personal view. But Bruno, what do you think?
I fully agree with you. I don't use this technique to advance the burr till the ostium of the guiding catheter. I stay manual, and I don't use the Dynaglide to advance. But I know that some operators are using, but I fully agree with you that for me, it's not ideal to use it to advance the burr.
And just another question we've had about in-stent restenosis and the use of rotational atherectomy. They do mention that it's calcified in-stent restenosis, which will perhaps make it a bit easier. But just generally, perhaps a comment about rotational atherectomy and in-stent restenosis. Any thoughts? There was the artist trial, which was rather disappointing, but is it something you would ever use?
Personally, I don't use the rotational atherectomy to treat in-stent restenosis. So for me, it's not an ideal situation. No?
Okay.
I would agree.
Sagar, perhaps I could ask you about fast speeds. There are some myths around that if you speed it up, you're more likely to penetrate. Is there any literature or thoughts you've had from experience about too fast? And then perhaps you could have a discussion what the consensus document actually advises.
Sure. Again, there's been a big paradigm shift really in the optimal burst speeds for rotational atherectomy. And if you pick up an IFU for the actual burr, it still suggests speeds of 220,000 revolutions per minute. But that's really hark back to the original early days of rotational atherectomy. But we've come to learn from pieces of evidence that this is probably not the optimal. There's been some bench studies that show that slower burst speeds are associated with less platelet aggregation, and that was showed by Mark Reisman in some bench studies. So that's one argument for slower burst speeds. And another is that there have been at least 2 registries which have shown categorically that there is less restenosis with slower burst speeds, and by that I mean 140 to 160,000 revolutions per minute compared to 180 plus, achieving the same lesion success. And certainly I think that the view of most is that you do not need to use these very high historic burst speeds, and 135 to up to sort of 160, 180 is sufficient really for all lesions. Those are my views.
Bruno, do you what's your standard in your laboratory? What do you ask them?
Actually, I think that most of the case we start with 160, 170,000 revolution per minute. So it's the standard protocol that we use. But I know that the general recommendation is between 135 and 180,000 revolution per minute. But
when we had the consensus meeting, it was a very wide variation in practice, and most people felt very strongly about what their particular number was. But what is quite clear, I think, but doing 175 at 220,000 RPM is not really standard practice now, and it's the sort of thing really, if you are unable to penetrate a lesion using standard equipment, what would you do?
I mean, if you are
unable to get through a lesion with your 1.5 burr at 160,000 RPM, what would you do next?
I think I will downsize the size of the burr. It's the first step that is quite easy. If you are not able to penetrate with the 1.5, so you use quite simply the 125 millimeter burr. If you have the 125 millimeter burr, then you need patience. At a certain time you will cross. It's just a matter of patience. Sometimes also you need to improve your support. Sometimes it's also related to the fact that you did not choose the good guiding catheter, and it could be solved sometime by changing the guiding catheter.
So the guiding catheter helps the device push forward, and if your guide is out a little bit, the transmission of the force comes back rather than forward. So the guiding catheter is a key element to good rotational atherectomy technique.
If I can, so I'd absolutely agree with that. And I've got a little algorithm of things that I would do. So one is a step down. So if you're using a 1.215, you go to a 1.25, absolutely. Guide support is next, and also checking the position of the wire, because if the wire is not deep enough in the vessel, you just don't get that purchase that you need with your forward pushes. But those are sort of the steps that one takes.
That we have to
absolutely,
adapt.
And you've got to have you've got to approach it systematically.
So if we just go a little bit more on the technique, and we've got the speed, what about the runtime, Bruno? Is that something you've modified with contemporary practice, or have you?
We know that actually you are applying very short run time. It's normally less than 30 seconds, but in practice I think it's 10-15 seconds, no more, in order to limit the risk of distal embolization and some complication.
And so let's imagine you are doing it and your technician says, oh, your revs are coming down 20,000 RPM. Does that worry you? Do you do a modified? Do you change anything?
You mean
deceleration
is too important?
Too great.
That means that you have a bad technique. Normally, deceleration appears when you are too long inside the lesion, and it's something that you should absolutely avoid. You should never stop inside the lesion. You should always advance and retract the burr when you are rotating the burr.
Certainly, in my practice, my first engagement with a rotational atherectomy is always about 5 or 10 seconds, just to get a feel. Just see what we're dealing with. Is there going to be a lot of debulking here, a lot of modification? Will there be a lot of side effects if we engage too greatly? So whatever atherectomy, always the first run, very short, just see what you're dealing with. And then you can avoid potential problems, because sometimes it's difficult to gauge the calcific nature of each lesion. And I think that's an important learning point. Do you have any issues about the length of run, Sagar?
No, I'd agree absolutely that usually burr runs of less than 30 seconds are important. And in between, you're also giving time. In between each run, you're also giving time for heart rate and blood pressure to recover. And it's also important that patient preparation is important. So patients should always be hydrated well through the procedure. And certainly I have a low threshold for using peripheral vasoconstrictors, which don't increase the heart rate like phenylephrine. So in short burr runs, and optimize the patient in between as well, and just get a feel for what they're like.
Sagar, may I ask you another question? Beside the fact the time of the run, when you cross with the burr, how many runs are you performing? One more, two more? What is your standard practice once you have crossed the lesion?
That's a really, really good question. It's an important one as well. And everyone knows really that the burr wobbles. It doesn't cut the same path. And so once you've gone through, the job's not done. And I will then go through a number of times polishing runs, making sure that there's no pitch change, that the burr speed isn't coming down, and that the burr visually isn't sticking. And then once I've done, and sometimes I will do 7 or 8 sort of quick polishing runs, and they can be reasonably brisk, to make sure that you've done the maximum work from that burr.
So to summarize, 1 to cross and 2 or 3 polishing runs.
Sometimes even longer with those factors, but yes, polishing is important.
If I could just move on now to the flush that bathes the equipment while we do this. Bruno, perhaps I could ask you, why do we have the flush, and what's its function? Perhaps if we didn't put it on, what would happen?
If we don't put flush, then you will have an elevation of the heat at the level of the burr, and the console has a safety system, and it could stop. And I have seen one case where my colleague didn't check the problem of the saline fluid, so the saline was flushing a little bit too fast. So when he was activating the burr and doing his rotablation, there was no more fluid passing, and the burr stopped. So you have really to take care of that. Huh?
Yeah, and within the saline, do you have a cocktail?
We gave actually heparin and some nitrates.
Okay, I think in the consensus document they add a little bit of verapamil as well, and that was always the traditional cocktail. And I have to say there's very little evidence for any of this, except that clearly it has to be bathed with some fluid to prevent the problems with heat. And I think I've always had the cocktail and have not had a problem, but I think others have, and so it's something perhaps which we may need to have some more data on before we can be definitive about it. But I think the consensus document has sort of gone back to what the traditional use has been, pending any further data. Now, after you've had a successful run of your lesion, what do you do? Do you step up? Do you do an IVUS? Do you do an angiogram? Do you test with a balloon?
Quite simple. Huh? After the rotablation, I go with a balloon. I try to open the lesion with the balloon, and if I'm successful, then I continue with delivery the stent.
Even after a 125?
Even after a 125. The goal, Adam, and I will repeat, is just plaque modification. It's just plaque modification. We don't need to treat fully the lesion by debulking.
And do you agree that so big 3.5 millimeter vessel, you've done a 125, you'll get the balloon out straight away?
I would agree with Bruno, absolutely. I've got many cases where it's a napkin ring of calcium, even in the big vessel, you've attacked it with a 125 burr, you've done a test dilatation, you've got expansion. If you get expansion, that's what you're trying to achieve with your test balloon. So I will keep the wire down, which I'm sure everyone agrees, is keep the rotablator wire down, send a parallel wire, balloon on that. If you've got expansion, you're done. And if not, then the wire is there and you can then go on with the second burr. But you do not need to step burr every case. Burr, test, and then decide is the mantra, really, I think.
Just a sort of point that's come up in the discussion from my colleagues around and about. What happens if halfway through the case you press the button and nothing happens? What would be your troubleshooting for the diagnosis of that problem? So you've been rotablating happily, and then suddenly you press the power and there's nothing happening. Sagar.
I mean, if you've obviously been rotablating initially, there's a few things that you've got to check. I mean, it's happened to me once, and actually where the registrar has tightened the TUI Bors a little too tightly, and that actually has gripped the Teflon coat on the shaft and stopped it. Yeah. So it makes a whiz and then it stalls. But the other things you've got to check, obviously, is that your gas cylinder hasn't run out, so you need to look at the gas cylinder and make sure there's enough adequate pressure in that, and from the training people will know what sort of pressure they need for their cylinder, and that your connections haven't come apart, because sometimes that can happen. So looking at those three things, I think, is what your sequence should be.
Yes, one of the things I found is it's rarely the equipment that fails. It's nearly always one of the steps you have to go through to make sure that you have made the equipment work as it should.
Correct.
Yeah. Okay, so if I could just summarize for the European guidelines, the guide catheter selection generally these days, most rotational atherectomy can be done with 6 French single curve catheters. Most procedures will now be done with the floppy wire. Any tricky anatomy, don't try and put a very difficult to manipulate wire, but use your standard wire. Exchange techniques using microcatheters have made this problem fine. We're told there may be some newer wires that might be available to facilitate wire placement, but I have to say with these modern techniques, what used to be quite a big problem has largely been resolved. So I think we've heard that single small burrs can account for the majority of cases that we do, and we didn't discuss it at length, but the use of temporary pacemakers, which used to be routine, particularly for dominant right coronary arteries or left mains, are now no longer routinely required. But I think one has to have your antennae aware that occasionally prolonged runs or unexpected distal embolization may lead to arrhythmias which might need some action. We've discussed the ablation speed, which we think should be between 135,000 and 180,000. The run speed, short durations. Many of us do much less than 30 seconds, but certainly prolonged runs are no longer advised. And the burring technique was very nicely demonstrated using a pecking and avoiding the dotting and the pushing techniques. Deceleration should be avoided and is usually a technical issue which needs to be considered with your equipment. And we downsize the burr if we're unable to pass, rather than increasing the speed and pushing harder. The rotablation flush, we agreed there is some dispute about what's standard, but for the time being, the consensus document at least will advise verapamil nitrates and heparin. And we stop when we think there's sufficient plaque modification, and that is based on the use of a balloon inflation to decide whether or not we should be able to get our stent in. So for the last part of the webinar, we're going to have a focus on complications. Now, just to put this in perspective, rotational atherectomy has been associated by its traditional use with heavy burrs, high speeds, in order to debulk arteries. There has been a raft of complications associated with trying to achieve that. And that's rather haunted the device into contemporary practice, which is now completely different, with smaller burrs and shorter runs. And so the traditional complications, they still exist, and we're going to see a few of them and have a chat about how to avoid them. But the strong message from us about complications is if you learn how to rotablate with good technique, then the complications will be much, much less. And having seen most of the complications that have happened in the UK over the last 15 years, I can assure you that they are nearly always due to the operator and not the equipment. So it's quite difficult to see this case, but I think with a little bit of dialogue from Sagar, he'll be able to understand. This is a case where a wire has caused a problem. Is that right, Sagar?
Yeah, so this is a rotational atherectomy case of the left anterior descending, and basically the rotor wire floppy was just passed in a very distal location. And this case really just illustrates the fragility of the platinum spring coil tip. And what you can see from this video clip is basically is that the wire has been withdrawn, but the platinum tip has actually sheared, so that there is some remaining platinum tip in the actual vessel. very distally, and so that's just an example really of the fragility of the distal tip. So the message really is place it distally but not embedded into a small vessel.
And it emphasises the point when we talked about the wire is the less manipulation of the wire itself. So do all the hard work with your workhorse wire, use the microcatheter, and then delicately place it in the main true lumen of the main vessel and just leave it there. If you start getting involved in angles and corners, that fragility of the end piece can become quite a problem. And I think some of us have seen cases where it's been excised or extended and can cause a problem. Do you have any experience, Bruno?
Yes, I will say that it's a very fragile wire, and we have to keep an eye on this wire during all the procedure. Do not hesitate to replace the wire if it's going in a small branch. It's very important because sometimes this problem arises because we are in a small branch. Keep an eye also at the exit of the guiding catheter because sometimes you may have a loop, and because it's a very thin wire, you cannot show the loop, and if you have the loop, you may have some problem. So really, and if you have any damage, if you see that the wire is kinked, do not hesitate. Change it and take a new one. So really, it's completely different than the wire that we use. And when I discuss with younger colleagues, they are used to very, easy wire. They don't take care. They advance even like this. With the rota wire, it's completely different, and you should be very cautious.
So the rotor wire, treat it carefully. It's vulnerable to rough handling. And using modern wires and microcatheters, we can avoid, hopefully, most of the problems that has been traditionally associated with it. Bruno, one of the other things that can happen is if you are too aggressive, you can get no reflow.
Yeah.
Something, again, strongly associated with it, but is rarely seen in day-to-day practice. Let's imagine you did have that. Do you have any tips that you could do about treating it, or perhaps even avoiding it?
It's a long time that I haven't seen some no reflow, because now we are using smaller burr and very short run. It's something that's very rare. But if it happens, the first thing is to higher the blood pressure of the patient, because sometimes you have a clear drop of the pressure, and then you stop for sure the rotablation.
It's a point we've had actually from the webinar community, where someone says, what happens if you do get hypotension after your runs? Yeah. And there's an implication in their question whether it's actually due to the nitro that's in the saline flush. But do you have any tips about that? And clearly, you should have good blood pressure to do any form of rotational atherectomy. And of course, if you have someone with very poor LV function, or someone is generally hypotensive, it needs to be aggressively treated. Any tips there?
Yeah, I think it's a point that it does happen sometimes. I always pressurise the cocktail to 300 millimetres mercury, and that will generate a drip speed normally of about 7 mils a minute. And some people reduce the speed of the drip rate, and that can reduce your hypotensive effects, because certainly some people will be susceptible systemically to hypotension from the verapamil and the nitrate. So if that is the case, then obviously keeping the patient hydrated is important. Boluses of phenylephrine to bolster blood pressure without affecting heart rate. So those are the steps that I would take, and sometimes I will even just switch off the flush in between runs if I think there's a systemic effect from the actual infusate. But you've got to remember to switch it back on, and that's why I think control from the table is important. So I always turn a stopcock myself, and so that we can't blame a nurse or a technician for that, which is a potential.
Another comment that I could say is that for patients with poor LV function, normally, rotablation is quite contraindication. So I will say that if you have to face a complex angioplasty with a patient with a poor LV function, probably if you can avoid rotablation, it's better.
We're just going to go a little bit back a bit. There's some comments about the techniques that people are interested in. Do you have any views on very angulated lesions off the left main, say a 120 degree bend off into the circumflex? Would you have any avoidance techniques or any tips that you would to embrace a very calcified lesion which had a very tortuous angle into it?
Well, for a very tortuous angulation and a calcified angulation on the circumflex, I use normally a 125 millimeter burr. It's clearly the situation where you will downside the size of the burr.
Okay, and you've not run into any problems as a result of getting stuck, or? It may be perhaps with the Guidezilla catheter giving you a bit more support round that bend with some of these modern techniques, which not a lot of us have got a great deal of experience about. But generally, one would teach caution towards rotational atherectomy is not sometimes used around very extreme angulated bends, particularly if there's calcium. And I think there should be some judgment before you start about whether it is the best technique, because you can get yourself into a bit of a pickle. Sagar?
I think absolutely. I would agree certainly with Bruno's comment that you use a small burr size, but clearly if it's clinically indicated, if you have nowhere to go, the patient has no option for surgery, then you have to take it, but accept that there is an increased risk. And I think that's also important in the decision making and counselling of the patient and their family, that there is an increased risk. But to make a comment also that what you can sometimes get in those very, very angulated lesions is the wire gets buried into the plaque. And sometimes replacing the wire, if that is the case fluoroscopically, sometimes you can see it, is a technique. But absolutely I'd agree, approach with caution, use a 1.25 millimetre burr and just have your antennae ready for potential serious complications, which you should in all rotational atherectomy cases.
And I think it goes on in a comment about training, really. It's certainly not the sort of cases you should be involved with in your first 20 or 50. And certainly if you have very complex cases, I think perhaps doing it together with an experienced operator is always very good clinical practice, which usually our timetables make it difficult to achieve. But it's something which I think doing cases with experienced operators can be very helpful for training. Just another comment, perhaps, the cutting or the scoring balloon has been mentioned. Briefly, let's say, when might you use those to facilitate the stent deployment?
Okay, I will use it most of the time in a fibrotic lesion, for example, and the other situation is a very short calcified lesion. I will say that in very long diffuse disease, most of the time the profile of this device are not sufficient to cross. The problem is that when you try the cutting balloon or when you try the scoring balloon, it will not cross the lesion. So now I am moving directly to the rotablation.
Any thoughts?
Yeah, I would agree with that. And also, I'm certainly not a fan of those balloons as a first-off strategy. And in my experience, I think rotational atherectomy as an option to scoring cutting balloons is actually, I think, a safer, more predictable outcome actually with rotational atherectomy. If after you have burred and exhausted your burr options through that guide and you don't want to use an alternative access with a larger burr, then it's entirely reasonable to employ a scoring balloon, cutting balloon after you have burred, rather than going to another access. But coming to the question as to whether or not you would use it as an alternative, I favour not. I think rotational atherectomy is a more predictable strategy.
There's a very good question about technique and how to avoid the jumping forward of the burr when you activate it. And any tips that you can try and avoid that? 'Cause sometimes there's a lot of tension in the system when you've placed the burr in what you think is an appropriate place, and when you activate it, it moves forward. Is there any tips you can transmit to us to avoid that? Bruno?
Well, in fact, when you cross, sometimes it's at the moment where you are, just exit of the guiding. It's sometimes the moment where, and so you have to sometimes modify a little bit the position of the guiding, so you'll release a little bit the tension. On the burr. So it's sometimes that's I think the key point. When you want to release the tension, it's just after the exit of the guiding.
And on the manifold itself, I think there's a little tip which is quite useful.
Yeah, I've got it in front of me, so I'll demonstrate if that's
it's yours now.
Okay. So when I train, I always advise basically to lock when you're advancing the burr, to actually give yourself about 1.5 centimetres sort of safety distance. Then I always park the burr at least 1 centimetre proximal to the lesion. And I open this and then test and see, ready to spring it back, because sometimes there's stored energy in the spring cord, particularly in tortuous vessels coming from the arm or the leg, which leads to it lurching forward as you release the tension on that initial run. And people have buried the burr in the lesion by being too close and with that spring forward that you're mentioning. So I think I'm glad that someone's raised that point, because that's something that I do, which I'm sure you do too, Bruno.
So you summarize, you advance balance the burr like this, okay?
Lock it there. So
Like-
when I advance into
yeah.
the vessel,
Correct, yeah.
yeah,
Perfect,
and then give myself a good safety distance proximal to the lesion to just test it with this open to
and
move
then
it back.
you release a little bit.
Yeah.
Okay,
Yeah.
very nice.
It takes us very nicely on to the stuck burr. Something which I think is, it's the sort of thing you see at meetings, and it's an occasional phenomenon, usually related to technique. But let's assume we've got the case that the audience can see on their screens now, where a burr is stuck in an LAD. Perhaps we could ask any solutions or avoidance techniques for the stuck burr, Bruno?
Oh, to avoid the stuck burr is in general related to once again on the fact that we have too long run and we stay a little bit too much in front of the lesion. We try to daughter the lesion and suddenly pop up. So that's why he will be stuck. And remember, that's a technical point, but there is no diamond on the proximal part of the burr. That explains that after, if it's stuck, you cannot remove it just by spinning. So you should stop spinning. It's the first point.
Yes, it's always a rather depressing noise when you press the pedal and nothing happens and the burr's stuck. Clearly, if there's flow down the artery and there's no compromise in degeneration, it gives you a little bit of time to have a think about some solutions for this. Perhaps Sagar, do you have any thoughts about some of the cases you may have seen, perhaps not through personal use, but some of your experience?
So just coming back to Bruno's point, absolutely. I think it's 9 times out of 10, it is actually due to operator error. And it's usually just due to, in my opinion, just too aggressive, pushing forwards. It jumps through a fibrocalcific spot and then wedges. And then the torque in the advance is overcome and it's stalled. And then, as Bruno says, you can't burr yourself out of trouble because there's no diamond chip on the back end of the burr. Okay, so what do you do in that situation? There was a European paper of 400 cases where they had an incidence of burr stuck of about 1% and managed all of them percutaneously. I have to say, we have never, in our history of our rotablation experience at our centre, ever had to send anyone to surgery. We've always retrieved them percutaneously. My own personal is that, first of all, you need to check on the hemodynamics of the patient. If obviously the burr is stuck and you've got poor flow, you need to do something quickly. My usual is to disengage the guide catheter and to give a really firm tug really on the burr, making sure the guide catheter doesn't dive in and cause aorto-osteal dissection, because that complicates a lot of cases that I've come across, but not in our centre. The alternative technique, if you've tried that and really given it a good pull, because this is bonded very well to the shaft, is to use the parallel guide catheter technique. The ping pong technique, where you get an alternative access, send through another guide catheter, pass a wire down, and then get a balloon down beside the burr to dilate and to release the tension in the vessel to pull the burr back, and that is effective too.
I think the point is you have to do something different. You've got something which is jammed. You can put a guide catheter or an internal catheter right down on top of it to get some tension. But nearly always, I think the cases which have got very jammed, it's always been this ping pong technique that seems to have been the successful way of getting themselves out of a problem. But the key message is to avoid it, and it's nearly always a technical problem that get yourselves into it, but occasionally you will come across it, and hopefully some of those comments from Sagar will be helpful if you're unlucky to have that. Some other questions. What's our opinion on heart block? And is that something that we have to contend with? Is it related to runtime, lesion site, proximal, right, left, distal? Any comments?
So, I mean, my reading of the situation, and in nearly all cases it occurs in a dominant right or dominant circumflex, rarely in the LAD, and it's believed to be just due to particulate debris going down the AV nodal artery. It's always transient, but obviously can destabilise a patient. I would agree in our discussions earlier that it is a really quite random thing, and you can't, there'll be lesions when you think, well, I'm definitely going to pace here and no pacing is necessary, and other times when it's a relatively short lesion and they require it. So it is, to a degree, unpredictable, but because it is short-lived, usually, you can just stop burring, give give time for it to recover. No one ever leaves the lab requiring pacing. And I think that has therefore reduced the need for a pacemaker. But I will always have it ready. But I think the emphasis also is in using as safe as pacing wire. And there are pacing wires and pacing wires. And some of the balloon tip 5 French very atraumatic pacing wires definitely have got a place in this.
Certainly, when some of the more aggressive techniques I saw in the past, where they use pacing wires, but also 2B3A inhibitors, was a recipe for potential bleeding and problems from right RV perforation. And interestingly, these newer sort of gentler techniques means that it rarely happens, and if it does, it's usually very temporary. Is that your experience?
Yeah,
Bruno?
exactly. And in general, what happened is that I shortened the duration of the burr. If, for example, this AV block arrive after 15 seconds, then the next run will be only 10 seconds, and it will not occur.
So the stuck burr, poor technique, we think, aggressive pushing, perhaps tortuosity does increase the risk. Stopping the burr in the lesion is a big no-no, and sometimes you've chosen a too big a burr, and it's the lesion's just too much for it. Some comments about perforation. Again, the incidence of perforation in large registries, both from the UK and Japan, indicate that it's slightly more than non-rotablation, but it's not a great deal more. And generally, the same message for all complications. If you use your good technique, make good choices, then you'll avoid a problem which can be quite difficult, because obviously perforation with a device such as this can sometimes be a type 3, and you can get yourselves into quite a pickle if that does happen. Generally, the burr's too big, it's too tortuous, the techniques are too aggressive, and in my experience, in the cases I've seen, it's rigid tortuosity is usually the culprit. And obviously treating it is the same for any perforation. There's nothing particular about the rotational atherectomy perforation that requires anything other than stopping the flow and putting a stent in that will get on top of it. But certainly, if all of us have had very occasional experience of it, and it's something you need to be aware of in your lab as possibly having a slightly increased risk. So overall, from the complication session, avoid them by doing rotational atherectomy with good technique. If you're not as experienced as you'd like to be, try and do it with an experienced operator and get more confidence with the device. And my experience is that the complications are nearly always due to decision making and the operator, and it's rarely a problem for the equipment. Just some final questions from the floor. Do you have any specific indications for rotational atherectomy, just briefly, Bruno, that we haven't covered? Obviously, it's been very focused on undilatable calcified lesions. Are there any niche things that you use it for in your daily practice?
I don't remember other technique. Usually for calcified lesion, I will say. More and more I use it up front before any difficulty. So I will say that the main indication is calcified lesion.
There is some data, although none of it's randomized, about in bifurcations, trying to avoid carina shift by debulking the ostium of the side branch. Have you? Not in your practice?
No, not in my practice.
Sagar,
no,
have you seen anything?
I've used it in bifurcation. The primary indication, it has to be calcified anatomy.
Yeah.
I wouldn't use it in a non-calcified. I think you're going to get yourself into trouble, and people question, whether or not that's the right thing to do. So I think as long as the anatomy is calcified, then yes, it's reasonable to use it in a bifurcation, but not per bifurcation per se. So I certainly wouldn't do that.
So, take-home messages from this webinar. Read the European consensus document, and these are the new rules from that document. Smaller burr sizes, slower speeds, shorter runs, plaque modification, not debulking. And if you do that, you'll take on very complex calcified lesions, and you'll get very good outcomes without complications. And if you use the techniques we've described and mulled over with our experts here today, then hopefully you'll be able to embrace this technology with much more confidence. On behalf of my colleagues, I'd like to thank the PCR team for the support in preparing the webinar, and in particular Boston Scientific supporting this independent series of educational program. I hope you can make the time to join the second webinar on calcified lesions, which will be later on in the year on Friday the 23rd of November 2018. That'll be a live case with my colleagues Emanuela Barbato and Didier Carrier from Toulouse, and we will have the new rotational atherectomy system and we'll see a case from start to finish. And also in that webinar, we're going to review the use of this technology in different anatomical subsets. If you've got any comments or feedback from our webinar, which we'd appreciate it if you could take the time to write in. And we're very grateful for the huge number of questions, some of which we've only had time to cover for, but it has made it a very interesting and stimulating webinar. Finally, I'd like to thank my colleagues, Sagar Doshi and Bruno Farah, who I think have stood up to my questioning with great skill, and my great thanks to them. Okay, goodbye for now.